Everyone, welcome to the RCC IMRT 2.0 course. Today, Dr. Paulina Galavis is going to be giving a presentation. If you have any questions, you feel free to post them in chat or use the raise your hand feature, and we'll get to them when we can. Thank you.
Thank you, Dean. Okay, so this is the outline that I have for you today. So I'm going to give you a brief introduction about the challenges that we face when we do IMRT dosimetry, and then the detectors that we should be using, or the recommended ones. Also, I'm going to talk a little bit about the phantoms that we have available. And also at the end, I'm going to talk about the detector selection for IMRT commissioning, and I'm going to focus a little bit on what we use in my clinic based on my experience. So when we talked about IMRT dosimetry, we are facing penumbra and peripheral dose. They can contribute to the final field dose measurements. And also we are dealing with steep dose gradient regions, even within the target. Also, we have to keep in mind that we have affluence, shape, and intensity that they are changing across the treatment. Also, please, before you start doing dosimetry for IMRT, make sure that you are familiar with the TG120, with the task group 119 as well. And also use publications. There are many very good papers where they compare different detectors, and that's useful for you to know, because sometimes you have to face the reality in your clinic that you don't have all of them to your disposal. So it's good that you go back and you review the literature before you start using any particular detector. So according to the TG120, they recommend that you verify the dose at different points. Also, that you should do a quality assurance, concentrating on the cumulative delivery dose instead of individual field segments. And also that you should verify the absolute position of the dose gradients. So what characteristics should the detectors have? This is in general. This is not only applicable for IMRT, but this is applicable for any type of detector or any type of measurement that you are doing in your clinic. Is your detector useful for absolute dose measurement versus relative dose measurements? What is the size of your detector? The stability? Is your detector energy dependence or directional dependence? Do you have any stem effects issues or cable issues as well? So when we talked about detectors, you know, we have our champion, the ion chambers, but we can also use diodes depending on the type of measurements that we want to do. And for the diodes, we can classify them into the silicon versus the diamond detector. You can use also TLDS and MOSFETs if you want to do point measurements. These are just examples of an ion chamber, a small volume ion chamber. And this is an example of the MOSFET detectors. So according to TG106, they classified, or they divided the ion chambers based on their active volume. And they came out with this way to define the different type of ion chambers that we use in the clinic. So we have the standard chamber, and that's the regular farmer that we use, you know, for our TG51 measurements. And it has a volume of about 0.6 cubic centimeters. And then we have the mini chamber with a volume, you know, in average of 0.05 cubic centimeters. And then we have the micro chambers with a very tiny volume, is 0.07 cubic centimeters. According to TG106, the microchambers are ideal for cyberknife and IMRT. What are the advantages that the ion chambers offer to us? So in the context of IMRT, we need a small volume ion chamber. They usually range up to 0.01 cc's or cubic centimeters. They're very stable. And the good thing about ion chambers is that if we send them for calibration every 2 years, they are NIST traceable for absolute dose measurements. They show a very small directional dependence, and they show a linear dose response. However, every detector you are going to encounter some disadvantages. So what disadvantages do we have for ion chambers? They give a volume averaging effect, and we need to pay attention in the regions of high gradient in the context of IMRT. So, and what is this averaging effect referring to? So when you are using an ion chamber, you have to keep in mind that you are collecting your ions through the active volume cavity of the chamber. So this averaging effect, it causes a perturbation on your dose measurements, especially in the penumbra region. Depending on the design of your ion chambers, there are some that they use a high Z central electrode, and this introduces energy dependence in the response, because what these type of ion chambers are doing is that they are over responding to low energy photons. And also you might have an stem effect with ion chambers. Especially, this is very critical for the small volume ones type of chamber. And this is related to how stable is your chamber, depending if a portion of the cables are in the beam when you are taking your measurements. So as I mentioned before, the ion chambers, they are ideal for absolute dosimetry if you have a calibration factor for your chamber, or if this has been cross-calibrated with a chamber that has been calibrated. So you might verify your monitor units, you can verify the dose to the target or critical structures, you can measure the output factors if the fields are not too small. So we refer to fields being too small when they are below 3 by 3 square centimeters. You should be using ion chambers on areas of dose homogeneity. And this is more when you want to do, for example, patient-specific QA, or when you want to test after you have commissioned your treatment planning system. But I will talk more about this in our next lecture. And also for comparisons, it's very useful if you calculate the dose through the ion chamber active volume by contouring the active volume of your ion chamber in the treatment planning system. So according to the TG106, the ion chambers are not recommended to measure intensity and for penumbra profiles used for beam modeling. Now we have the silicon diodes. They give you a very small active volume compared to an ion chamber. They give you a very high, they are very sensitive. However, they give you some disadvantage as well. You have to keep an eye on diodes because they change in sensitivity over time. They get damaged by the radiation. They show some over response to low energy photons, and they have some angular dependence as well as some energy dependence. They are ideal for relative dosimetry and for measurements of high gradient dose regions. However, you need to pay attention to the diode orientation with respect to the beam. And remember that you need to monitor the sensitivity of the detector because this is going to decrease over time. They are not recommended to use. For example, do not use in vivo diodes to place it inside phantom for measurements. And also for measurements of peripheral dose profiles for beam modeling. Now, we also have at our disposal diamond detectors. They are a very small active volume. They are near tissue equivalent, and they give a very high radiation sensitivity. However, they show a very small radiation dependence, and the disadvantage is they are very expensive compared to the regular diodes or the ion chambers. And they show some dose rate dependence. We can use also TLDs. These are nearly tissue equivalent. They are small in size. And in the context of IMRT, the chips and rods, they are the most commonly used. You don't need cables to use TLDs. However, to have a readout for the TLDs, it takes time. They show a nonlinear dose response, and they are energy dependent. They are ideal for in-phantom measurements when you want to do multiple point measurements at a time. And the ideal ones are the lithium fluoride type of TLD because these are the ones who are tissue equivalent. You have to be very strict following the handling, annealing, and calibration protocols. For example, in my clinic, we don't have TLDs. We don't have capability to use them. And do not use TLDs if you need a precision below 3%, 3 to 5%. Now you can use the MOSFETs. They are very small in size. You can have an immediate readout. They show a linear response, and they have a very small directional dependence. However, the disadvantage is because they are diodes. They change in sensitivity over time because they get damaged due to the radiation. They are not tissue equivalent, and they show some energy dependence. We don't, for example, in my clinic, we don't have MOSFETs detectors. They are ideal for situations needing immediate readout. You can have multiple dose measurements. Do not use MOSFET detectors if you want to do dose measurement needing a precision below 3 to 5%. Now we are going to switch to the 2D type of detectors. So for this one, we can use films or this type of array detectors. So for films, we can use the radiographic or the radiochromic film. And for the array type of detectors, we have an array of ion chambers, or we can have an array of diodes. They give us a very high spatial resolution. They are relatively inexpensive. And in the context of IMRT, the film of choice is the EDR2. And this is because they are able to provide a linear response up to like 500 centigrades, if I recall well. In our clinic, we don't have a film processor anymore. So we currently, we don't use radiographic film, we use radiochromic film. So the disadvantage of the radiographic film is that you need you need to have a film processing, and they are light sensitive. So you have to keep them in the dark room. They are very sensitive to low energy photons. They have a dependence on the film batch, on the processing conditions, and how do you do your digitalization. And they need a calibration curve for each batch. So they are ideal for relative planar dose measurements, for penumbra dose profile for beam modeling, because they have a very high spatial resolution. You can use them for relative output factors for small field dosimetry. I know that they use them in gamma knife, for example. And please, if you planning on using radiographic film, there is a task group, TG69, where you can read it, and they explain all the recommendations how to handle the radiographic film. Do not use radiographic film for absolute dose measurements. Now we have the radiochromic film. This is the one that we use in my clinic. So they give you high spatial resolution. They are ideal because they don't require to have a film processing equipment. They are nearly tissue equivalent. They are not sensitive to indoor light, so you can handle it without any issue. They are less sensitive to low energy photons. Of course, they have some disadvantages. You need to wait at least 24 hours before you can processing your film after you have exposed it. And they are very susceptible to scanner artifacts. And also, you need to measure a response curve for each experiment. However, this is very easy to do. So what you need to do is like maybe cut like 3 by 3 squares of radiochromic film, then expose it to different doses, and then you create your calibration curve. In terms of the scanner, how do you scan them? As long as you have a procedure on how to position the radiochromic film on the scanner, and that's what your clinic follows, we haven't encountered any issue if we follow our standard procedure. What you need to keep in mind is that if you are scanning multiple sheets of radiochromic film, the temperature of the scanner increases, so that might introduce some artifacts into your readings. So they are ideal for relative planar dose measurements, for output factors, for small field dosimetry, for penumbra of profiles, again for a small field dosimetry. Do not use radiochromic. Also, you can use radiochromic films for, your star shots when you are doing your Arnolds on the machine. Now,
hi, Paulina. Can I just ask a question about films that was posted in the chat?
Yes.
Okay, so the question was, how would you compare EDR2 films to EBT3 films for IMRT QA? I think that relates to maybe how they differ, or what an advantage of one over the other might be.
If you use the radiochromic versus the radiographic?
Yeah, I believe so.
Okay. So I think that the main difference is that chromic, you don't have to use, the advantage is that you don't have to use a film processor. In my clinic, we don't use radiochromic film for patient-specific QA. We use an array of diode detectors. We use map check.
Okay, we can use the film in combination with an ion chamber to do patient-specific dosimetry, though, right?
Yes, yes,
Okay.
we can. My recommendation, because it gets very tricky, I have some experience, for example, with Tomo, using the cheese phantom. So when you place, you have to make sure about the positioning of your film in the phantom, because then you have to scan it, you have to process it, right? And then you have to take that exposed film to your treatment planning system, and you need to align it. I mean, it's more involved, but because when you do films plus an ion chamber, you are taking only one plane of your QA, and then you are taking an absolute dose measurement. Is that answering his question or her question?
If that's answering the question, you can post that in the chat, or if you have further questions, we can get to it at the end. Thank you. I do have one more, I think, quick question about films that was posted to me, and it is regarding EBT3 film for extended SSD. Can we use for TBI commissioning for cross-verification of data taken from the ionization chamber? And specifically, the follow-up to that was, due to high spatial resolution, they had faced noisy PDD data at extended SSD at about 500 cm. And is there a way to filter those noises?
I don't have experience using a film for a TBI. What I have done in my clinic, we measure TMR tables using an ion chamber and solid water. But we don't use, again, we don't have film, and the radiochromic film is small.
Okay.
But I want to ask around about that question for the TBI, and then I might get back to you, Tim.
Okay.
And maybe somehow we can answer the question maybe offline.
Yeah, I can send it to probably Ben or Faye and hopefully get it circulated.
Yes.
And I'll send you the exact question.
Okay.
Thank you so much. Appreciate it.
No, thank you for the questions. I was here, right? Yes. So now we might use a 2D array of detectors, either ion chamber or diode array detectors. It gives you an immediate readout. It's easy to use. They are not traceable to NIST. However, you can use it for absolute or relative dosimetry if you calibrate your array. This is what we use. This is an IC profiler. The profiler is an array of ion chambers. And this is the map check. This is an array of diodes. We use the map check for patient-specific QA for IMRT in my clinic. And for BMAT, like volumetric measurements, we use a different type of them. So the disadvantage of using an array of detector is that they have a lower spatial resolution. The detector spacing is usually, around 0.7 millimeters. They have a limited active area, and they require that the beam is normally incident into the array. They are ideal for patient-specific QA. However, you need to evaluate the stability before establishing your passing criteria. You can do relative and absolute planar dose measurements if you are using an array of ion chambers. Also, the map check, it has some capabilities for doing some machine QA testing. Do not use this type of detector array for initial IMRT commissioning, but they are very handy for end-to-end testing. In my next lecture, I'm going to show you, and again, it's going to be specific to my clinic, how we did one commissioning for one of our true beam machines. And I'm going to show you examples so you have a better picture about all these detector selection. So now we have been talking about the detectors, right? But these detectors we have to place it somewhere. So we use phantoms. We might use a water tank or solid water or what is called water equivalent slabs. We might also use anthropomorphic phantoms if they are available, or geometric phantoms. So the characteristics that we have for our phantoms is that they give us a detector positioning flexibility. They have fiducials for setup accuracy, and we need to do CT characterization before we use certain types of phantoms. Here I have examples of two water tanks that we have in my institution. So we have a round water tank and we have a square water tank. Now for the water tank, they give you a nice flexibility in detector positioning, different type of detectors. Remember that they need to be a water resistant detector. There are certain tricks that you can use to use detectors that they are not water resistant, but I wouldn't recommend those ones. The disadvantage of the water tanks is the beam orientation restriction. So here is the opening of the tanks, meaning that you don't have walls. So the beam will have to come from in this direction to do your measurements. There are some water tanks that they are like vendor driven, meaning that you cannot use vendors, a different type of vendors to place it in a specific water tank. For example, for this one, you have to use the same vendors. It doesn't take, for example, my detectors from the square water tank, I cannot use them in the round water tank. And that's something that you have to keep in mind when your clinic is buying the equipment. If you are involved in the buying, each institution is different, but keep that in mind. Keep in mind that if measurements are happening for a period of time in these big water tanks, algae might grow. However, there are some chemicals that you can buy and you can use in the water to prevent that from happening. There are also evaporation effects that you need to keep in mind when you are doing water tank measurements. So these big water tanks, they are ideal for beam scanning, to get your PDDs and your profiles, your TMRs. For point measurements, your output factors, especially for the big field sizes, attenuation factors, wedge factors, and of course, off-axis output factors. Also, you can use solid water. These are water equivalent material. That's why we call it solid water. They are easy and very convenient of use. However, you need to keep in mind that you need to do a custom cutout for your specific ion chambers and other detectors that you want to put, inside the solid water. It allows for you to use with films. You can use it for single or composite beam measurements. However, is limited to the detector position. So how they custom your cutout for your ion chamber. That's what this limited detector position is referring to. Anthropomorphic phantoms, they tend to be expensive. However, they give you a better simulation of human irradiation. They are useful for end-to-end testing of the overall IMRT planning and treatment. They are limited, they have a limited location of film and detector. It could be more difficult to determine the cause of any dose distribution discrepancies. In these cases, you might need to use a simpler geometric phantom. Here are two examples that we have in my clinic. These are the Sears phantom, and this is the homogeneous one. This is a Sears phantom, but this is a heterogeneous phantom, meaning that you have the long type of composition. And as you can see here, this phantom has different like rods or plugs that you can, you can put your ion chamber in any location to do those measurements. And these are ideal for end-to-end testing. In my experience, we usually start, with the ideal. Everything is homogeneous. You are testing your commissioning machine under the best representation, and then you are adding, more parameters or more variables. So it's easier for you to spot where you might have any issue. So when you are commissioning, it's very important that you know what type of measurement do you need to acquire. So it's very, very, very important that you are familiar with your treatment planning system by reading, your algorithm data collection requirement. You need to know what is your second MU calculation program. What do you need? So the data to be measured during the commissioning is user dependent, meaning that, for example, Eclipse from Variant is going to be different than Pinnacle, for example. So usually the scanning measurements that we need includes PDDs, our TMRs, beam profiles, and depending on these type of measurements that we know that we want to do, we can either select ion chambers or diodes or diamond detectors. But as I said before, sometimes we don't have all of them. We have some of them. So usually the ion chambers are the most widely used due to the availability, and they are not that expensive compared to other detectors. And there is a wide variety of commercially available ion chambers. So this is a list that is not a complete list, but these are from the TG120. And I included here so you have an idea. For example, in my clinic, we have IBA, we have the cylindrical ion chamber, the CC13, and we use the CC13 for scanning. We also have the nuclear cylindrical ion chamber, and we use it in the round water tank that I showed you because I cannot use my IBA ion chamber on my round water tank. So the selection of your ion chamber is going to depend on the field size, the resolution, and the application. So for example, most scanning systems, they use an ion chamber with an inner diameter between 4 and 6 millimeters, which are adequate for field sizes above 4 by 4 square centimeters. And this is what TG106 recommends. However, we are faced with our reality, right? With what we have to our disposal. In my clinic, we do PDDs and TMRs and beam profiles up to 3 by 3 square centimeters using the CC13 ion chamber or the SNC 125C from the zone nuclear. Later on, we bought a smaller plastic scintillator detector, and we compare our data between the SNC 125C, and we had a very nice of our PDDs and profiles. And I will show you some of these results in our next lecture. Okay. So for output factors measurements, we also use the SNC 125 or the CC13 up to 2 by 2 cm. The A16 ion chamber, it works well also for small fields. And the A12 ion chamber works well for bigger fields, meaning fields above 4 by 4 square centimeters. I thought that I highlighted these two. We have the SRADIN, A16, and A12 in the clinic. On the next lecture, I'm gonna show you like comparisons so you have a better idea on what we have and what we have used before. So diamond detectors, they can be used for beam scanning and output factors. Diodes can be used for scanning, output factor. However, keep in mind that there are diodes for photons and for electron beams. In our clinic, we use diodes for electron beam scanning and electron output factor. So now, talking about IMRT, we need to take measurements for our MLCs. And again, this is going to depend on your treatment planning system. You have to be familiar with your treatment planning system before you start collecting any data and before you decide how are you going to do your measurements. So you need to measure the interleaf leakage. You need to measure the intraleaf leakage as well. This is just the transmission through an MLC leaf. You need to measure the light and radiation field, the penumbra, and you have to do some measurements on the tone and groove effect across the field. So as a summary, there are multiple challenges that we face when we're doing IMRT dosimetry. We're dealing with small fields. We have a dynamic dose delivery. We have complex dose distribution with a steep dose gradient. Keep in mind that there is not a unique detector or a detector system that is adequate for IMRT commissioning. There is not a unique phantom for adequate IMRT commissioning. So you need to select your detector combination with a phantom for each type.
I have a couple of things that I think might be good to go over, either repeat or not. So one of my questions that I think is always interesting to ask is, do you have any recommendations for kind of the minimum requirements for ion chambers for IMRT commissioning or film? Like what combination would be like an absolute minimum that you could get by with? Do you have any idea? Or,
yes. So when you are doing your commissioning, there are two portions, right? There is the portion where you are gathering your data. And then there is the portion that after you gather your data, you go to your treatment planning system and you are doing your beam modeling with that data that you just collected. After you do your beam modeling, plans, right? And then after you do your plans, you have to go back to the machine and you have to deliver that treatment. So you need a combination of phantoms and ion chambers and diodes to collect the data. And then you need a combination of phantoms and ion chambers and maybe films to verify your commissioning, that your whole system is what you expect, that what you are looking at your treatment planning system is what your machine is delivering for you. Is that answering your question, Ting?
Yeah, so I think that that's definitely an important consideration. I was wondering if you could speak on, for instance, you need a farmer chamber and film to be able to perform IMRT.
So for example, if you don't have a 2D array to do patient-specific QA, then you need film plus an A16 ion chamber. The A12 is too big for IMRT. So you need an ion chamber with a smaller active volume in order to do your analysis. So the idea here is that you have, the film is gonna help you to see the isodose distribution, and your ion chamber is gonna help you to do a absolute dose measurement. When you use these two the arrays, you don't need to do a absolute dose measurement. That's the advantage of using, for example, the map check. In my experience using film, maybe I think more than 7 years ago, sometimes you will get a very nice passing film, your distance to agreement gamma, the 3%, 3 millimeters criterion, that will be nice, but you wouldn't pass your absolute dose measurement, and it's because you are putting your ion chamber in a very high dose gradient. So you have to go back to the treatment planning system, move the location of your ion chamber to a place where it's more homogeneous in order to get your dose absolute measurement to pass. And when I said to pass, we are looking at a discrepancy, at least when we were using films, it was below 5% between what is measured and what is compared from my treatment planning system. I'm gonna add for the next session, I'm gonna add this example, and I'm gonna specify the type of detector that we use and the results that we have seen so far.
Okay, great. That sounds good. Everybody can look forward to that in the next presentation. Is that the next one on Sunday?
On Monday.
Monday? Okay, so that'll be in the presentation on Monday.
Yes.
It doesn't look like no one's posted any additional questions that I can see. I don't know if anyone wants to.
Are we allowed to recommend some homework?
Yeah, I would say sure.
Okay, so everybody has homework for Monday. Please review TG120.
Okay, well, with that, I guess we'll wrap up this session today. Thank you very much, Paulina. It was a wonderful presentation. I hope everyone enjoyed and learned something that they didn't know before.
Thank you, Ting. Thank you, everybody. Have a good day.
Everyone, thank you for joining. Have a good day.
Thank you very much. Thank you for the presentation. Have a good